This afternoon you get Themo and Remo. So Remo, because that's the right way to pronounce it in Italian, asked me to be first so he can be second. So his lecture is going to be fresher in your minds. So I agreed because I think my position is much stronger. So moving on, and I want to thank Marla and Imedex for organizing this. And it's great that we're developing a community of IBD healthcare providers. We have DHAT, TDDC, UT Southwestern, Baylor, the whole metropolitan area represented here today. So, my answer to that, really putting aside jokes, is that both patient-reported outcomes, which is I interpret what the patient feels and reports. So both patient-reported outcomes and mucosal healing matter. So we'll all agree on that. I just want to make some points about mucosal healing. And I think we need to be circumspect about the notion of mucosal or endoscopic healing. I prefer the term endoscopic healing. It's not that it's all cracked up to be. So if I leave you with those sort of notions at the end of this lecture, then I think I will have been successful. So there's no question that symptom-based assessment has limitations in IBD, but especially so in Crohn's disease. So we know that patients who have Crohn's disease and coexistent IBS, they can have a very high CDI score despite no inflammatory activity. We know that. We've known that forever. Actually, that is not true, in my opinion, for ulcerative colitis. There is an excellent correlation between symptoms and endoscopic activity in ulcerative colitis. We know that for both diseases, more severe endoscopic activity predicts worse outcomes. And Remo is going to go over all these data. And I concede that. That's fine. And we know that endoscopic healing, independent of the mechanism, is associated with better outcomes. But, again, what are the con arguments against mucosal healing? I think a major argument against making mucosal or endoscopic healing a primary target is that it doesn't happen all that frequently. It's not feasible in many of our patients. So let's take the two seminal studies, of which Remo was the first author in one of these studies, that looked at the most effective therapeutic approaches, both in Crohn's disease and ulcerative colitis, namely in anti-TNF monotherapy and anti-TNF and thiopurine combination therapy. So in the SONIC study in Crohn's disease, endoscopic healing with infliximab at week 26 occurred in 30% of patients, and in the infliximab monotherapy arm, and in 44% of patients in the combination arm. So less than 50% of patients achieved endoscopic healing. And when the similar design study was conducted in ulcerative colitis, this was the study where Remo was the first author, the SUCCESS trial, the rates of healing at week 16 were 55% in infliximab monotherapy arm and 63% in the combination arm. So you can see that even using our best therapies right now, either anti-TNF monotherapy, or the even better, in my opinion, combination therapy with thiopurine, we do not achieve endoscopic healing frequently in most of our patients. So, okay, endoscopic healing is good. Can we achieve it in clinical practice? What's the clinical practice experience? And maybe Remo will have some more data, but this is really, in my opinion, the only study that I could find, and this is from Dr. Sanborn's UC San Diego cohort, where they basically escalated medical therapy to achieve endoscopic healing. That was the the target. That's the treatment to target. So these were patients referred to UC San Diego, okay, not their own cohort, who presumably are already being treated wonderfully. So these are 199 patients who are referred to San Diego. 171 of them were scoped. And of course, to document endoscopic healing, you need to do at least 2 endoscopies. And in this case, 110 of them had at least 2 endoscopies. And at the end, you only need to include only those patients who have disease at baseline, at the baseline endoscopy, right? So basically, the study was 67 patients with ulcers at baseline endoscopy, 23 with so-called deep ulcers, they don't define exactly what they mean, and 44 with superficial ulcers. So the adjustments that Sanborn and his group did were to introduce or switch the immunomodulators, so introduce thiopurine, introduce methotrexate, or switch from one to the other, and or introduce, optimize, or switch between different biologic classes. So what did these poor patients have to go through? Okay, so these 67 patients had to undergo 161 procedures within a median of 62 weeks, okay? 21 of them had 3 consecutive endoscopic procedures. I mean, by definition, they must have had at least 2 procedures, right? But a substantial proportion of them, 31%, had 3 endoscopic procedures, and almost 10% had 4 consecutive endoscopic procedures. So, and a median time between endoscopies was 24 weeks. I don't know, I mean, in my practice, I don't have a lot of patients who volunteer to have an endoscopy every 6 months, or even less frequently, more frequently. So after all this effort, it was all said and done, they saw endoscopic healing in less than 20% of these patients at 24 weeks, 42% at 52 weeks, and 50% at the end of follow-up period. And the predictors of endoscopic healing were repeating the endoscopy and adjusting therapy after, if the follow-up endoscopy shows persistent ulcers. So yes, endoscopic healing is feasible, but it requires a lot of effort on the part of the patient in terms of undergoing repeat procedures and on the part of the medical team. And moreover, it's got only a 50% chance of being effective. So moreover, we have to be circumspect about how capable we are in producing endoscopic healing. Our drugs are great, but every drug has a different mechanism of action. We don't have the perfect drug, and we can't expect in this multifactorial disease to achieve endoscopic healing because simply the drug works through a particular mechanism, and the disease has so many different parameters to it. Moreover, I would think that patients with more long-standing disease are more resistant to endoscopic healing. Again, that hasn't been proven, but it stands to common sense. And again, as we saw in that study, the approach represents a huge burden to the patient and to the healthcare system. So these are significant issues when we think about introducing endoscopic healing as a treatment target in our population out in the community. Moreover, people view endoscopic healing as a yes or no in a binary way, and we have ignored, in most studies, we have ignored the degree of endoscopic improvement. And what is the minimal degree of endoscopic improvement that is clinically relevant? For example, it reduces hospitalizations or surgeries. We don't know. One study that we have was this study from Germany, I believe, where they looked at patients with roughly 200 patients with Crohn's disease, and they were treated with infliximab, and they looked at major abdominal surgery, eye resection or stricturoplasty, depending on the induction of complete healing, partial healing, or no healing. And you'll see that patients who had partial healing had rates of surgery that were similar to those that had complete healing. So I think, number one, endoscopic healing is a very difficult aim to achieve, and patients who achieve less endoscopic response may do just as well. And so not only don't we have enough, I think, evidence to promulgate endoscopic healing as a treatment target, but some visionaries are moving the target even further. There's mission creep. So now we're going to go to endoscopic healing. Next thing we're going to go is to histologic healing, as if we are gods and we can remove intestinal inflammation. And next thing you know, we're going to be doing MRIs. I want to get Ed upset here, to follow up the transmural evolution of the disease. These are all interesting thoughts, but we live in the real world. And I think that let's not jump ahead of ourselves. And finally, there is no evidence from randomized controlled trials that endoscopic healing is clinically effective, and if it's effective, that it's effective in a cost-effective manner. And I looked at Remo's slides, and he's going to go over some trials they're designing out there, but I think the ideal trial, I think in this time and age, should be a trial that compares the most effective current approach that we have, which is combination therapy, anti-TNF plus azathioprine or methotrexate, to an alternate approach. Presumably, these will be patients who are being treated for the first time, or they may be patients who have failed some sort of prior therapy. And again, the difficult decision would be, what do we compare it to? Do we compare it to optimized dosing based on therapeutic drug levels? Do we change the immunomodulator? Do we change the anti-TNF? I mean, the design of this study, I think, represents significant challenges. And at the end of the day, I think that, I think if that study is ever done, it's probably going to be very large to achieve statistical significance. I think my prediction is that the benefit will be modest, and I think if this study incorporates patient-reported outcomes and costs, how willing are the patients to go through these procedures, how expensive it is, and all that, I think at the end of the day, we're not going to be incredibly happy with the results in terms of endoscopic healing. So my approach is always treat early. I think Remo went over this, his way of doing things. Use your first chance to treat the patient is your best chance. Use the most effective therapy. Optimize it. Evaluate the clinical response. You can consider evaluating endoscopic response at the appropriate time point, not too early. And then, if you're going to do something about it, yes, then do evaluate endoscopy follow-up, and then you have to decide where to go from there. And I hope that these trials that Remo is going to go over are really available to, are really run out of multiple centers around the country, because you need numbers in these kinds of patient scenarios. And so I'm going to leave you with this image. This is the island of Lindos in Greece, in Rhodes. And who speaks Greek here? I know some of you do. So Marla, what does this say? What's this? M, epsilon, tau, rho, o-n, metron. Metron, ariston. I think you all know Greek, you just don't know it. And so this was a saying by one of the 7 sages of Greek antiquity, Cleovulos of Lindos. And it basically says, that's where our modern saying, everything in moderation, comes from. Thank you.